Hello, and welcome to this RPTH research recap, where we dive a little deeper into the science being published at RPTH. My name is Frederic de Norme. I'm an assistant professor here at Washington University in St. Louis, and I'm pleased to introduce Nicolas Gendron. Dr. Gendron is a hematologist specializing in thrombosis and hemostasis at the European Hospital Georges Pompidou in Paris, France, and a postdoctoral research fellow in the Denisa Wagner Lab at Boston's Children's Hospital, Harvard Medical School in Boston, United States. Dr. Gendron recently published a paper in RPTH titled Relevance of anti-PF4 H antibodies and platelet activation in systemic inflammatory diseases and thrombosis disorders, insights from the COVID-19 pandemic. For those joining us live, please leave your comments and questions in the chat, which will be answered during the discussion part. Dr. Gendron, we look forward to hearing your presentation.
Thank you for this kind introduction. It's a great pleasure to be a part of this RPTH research recap on our paper focusing on the relevance of anti-PF4 heparin antibodies and platelet activation in systemic inflammatory disease and thrombosis disorder. As you know, COVID-19 following SARS-CoV-2 infection emerged as a pandemic associated with a high mortality rate linked to a coagulopathy and a endotheliopathy. It was observed a microthrombosis and macrothrombosis in those patients, and COVID-19 was associated with a high prevalence of venous thromboembolism in patients hospitalized for severe COVID-19 and particularly ICU patients. These high rates of VT in patients systematically treated with heparin for prophylaxis led to several heparin-induced thrombocytopenia, HIT, suspicion during this period. But at the end of December 2020, it was the beginning of the approval of different vaccine. And in Europe, European agency in January approves the AstraZeneca adenoviral vector vaccine to protect against COVID-19. But following the introduction, the beginning of the mass vaccination, several cases of thrombosis and thrombocytopenia were reported. And different group, one from Germany, one from Norway, and one from UK, described several patients who developed thrombosis and thrombocytopenia following AstraZeneca vaccination. All these patients with thrombosis, most of them had a cerebral venous sinus thrombosis, but all patients were positive for IgG anti-PF4 antibodies, and they had a platelet activation detected with functional assay. And this syndrome was called VITT for vaccine-induced immune thrombotic thrombocytopenia. And then following this description of this syndrome, that led in different countries to age restriction of vaccination, or in some countries, as in France, a switch to a vaccination with RNA vaccine, such as Pfizer. Early in this pandemic of VITT case, the ISTH developed some guidelines for VITT suspicion. ISTH guidelines propose to screen patients for VITT in case of a thrombosis following vaccination with adenoviral virus between 4 and 28 days, and to look for thrombocytopenia. And in case of thrombosis and thrombocytopenia, it's recommended to do anti-PF4 antibodies testing, and in case of positivity for confirmed VITT diagnosis, to perform a functional assay. Since the beginning of this pandemic, everybody seems interested in anti-PF4 antibodies. Dr. Bentunes from our team analyze the number of hemostasis tests reimbursed in France since the last 9 years. And he observed that in 2021, in comparison to the previous years, an increase of complete blood count, D-dimer, and anti-PF4 heparin testing, probably due to VITT suspicion and vaccine misinformation or disinformation. So in these studies, we wanted to investigate the relevance of anti-PF4 heparin antibody detection and platelet activation during COVID-19, but also after COVID-19 vaccination in the general population, but also in patients with systemic inflammatory disease. In the present study, we had access to several cohorts. I will try to be brief and describe all these cohorts. First, we had access to patients with COVID-19, to the Sarkozy study. So we include plasma from patients from the European Hospital Georges Pompidou in Paris. And this study was an observational cohort, including consecutive patients with SARS-CoV-2 infection suspicion. Then, as our center is one of the French reference laboratory for HAT diagnosis, we had a Paris Southwest network, and we could have a lot of suspicion of HAT, and we could, in this study, we could include, patients, consecutive patients with suspected HAT referred to our HAT team. For all these HAT suspected patients, the diagnosis was supported by clinical and laboratory data as recommended by guidelines. And the criteria for HAT suspicion were based on the 40 score. In case of intermediate or high probability of HAT probability with the 40 score, we performed IgG anti-PF4 heparin antibodies using ELISA, and all cases were confirmed with a functional assay. We also had access to several cohorts of controls. The first cohort was patient included before COVID-19, before COVID-19 vaccination, so before 2009. The second cohort was during the vaccination campaign, and including a patient with a systemic inflammatory disease and control from the Cochin hospitals. And both patients and control had samples of serum samples at day 0 before vaccination, 28 days after, and 3 months after vaccination. We also had access to sample to a cohort of healthcare workers from a prospective and multicentric cohort in Paris, the COVID-OP study. All these patients were sampled before and after vaccination. Finally, we also include patients with a thrombotic event following COVID-19 vaccination. We include first a cohort of patients from our hospital from a prospective monocentric study, including all inpatient and outpatient who had a VITT suspicion. And this VITT suspicion was any thrombotic events within 30 days after COVID-19 vaccination with any type of vaccine. We could also include 4 VITT confirmed patients previously described and with available serum at baseline or during follow-up. And concerning the materials of the study, we use for the detection of IgG anti-PF4 heparin antibodies the immunoassay from IFN, the ZIME test, and we use this test according to manufacturer's protocol. Indeed, patients were considered positive in case of optical density, OD, higher than 0.5. Patients were considered weakly weakly positive in case of optical density between 0.3 or 0.5, and they were considered negative in case of optical density below than 0.3. In poor plasma sample, in platelet poor plasma sample, we analyze a soluble p-selectin level in those patients. We use the serotonin release assay in this study to confirm HIT diagnosis, as recommended with low dose of heparin, 0.5 unit per ml or 0.5 unit per ml, and a supratherapeutic dose of 100 units per ml. In this project, we also analyze plasma and serum samples with flow cytometry, analyzing a platelet microparticule assay, evaluating the GP1B platelet receptor. As you can see on this figure, you have 2 patients with HIT suspicion. Both have positive anti-PF4 antibodies, but the HIT confirmed patient show a positivity of microparticule on the upper left side of the figure, and internalization of the GP1B at low dose of heparin, but not at supratherapeutic dose of heparin. We can observe the same pattern with VITT patients, positive at low dose of heparin, negative at supratherapeutic dose of heparin. But it's also, in this case, this patient was positive also without heparin, and it was negative with low dose of heparin with Fc gamma 2 inhibitor. So, concerning the result of our study, first, in 81 patients hospitalized for COVID-19 with plasma sampling at admission, we observed only one patient with a weakly positive result of anti-PF4 antibodies, but none of the patients had high positivity result for IgG anti-PF4 heparin. We observed no significant difference in anti-PF4 antibodies levels between the different groups, and we didn't observe a correlation between plasma level of soluble p-selectin and the level of IgG anti-PF4 heparin antibodies. Then we wanted to analyze only ICU COVID-19 patients with 2 sampling. One patient were intubated and at T0, and the second at T1, 7 days after. At T0, only one patient was weakly positive for IgG anti-PF4 heparin, and at T1, only one patient who was negative at T0 was positive at T1. We observed in the two sampling times no difference in IgG anti-PF4 heparin levels, and we also observed no correlation between the level of the anti-PF4 antibody and the level of soluble p-selectin in the plasma of this patient. Then we tested these 3 patients with positive or weakly positive anti-PF4 antibodies, and as you can see, using the flow cytometry assay evaluating platelet microparticule activation, we did not observe any platelet activation in comparison to HIT or VITT patients. Next, we analyze all the consecutive patients with HIT suspicion during COVID-19 outbreak, and we compare patients with during the same period, but in 2019. So, for example, between March 15 and April 15 in 2019, our HIT team had 17 HIT suspicion. Most of them had a 40 score higher than 3. All these patients were tested for anti-PF4 heparin antibodies. Only 4 of these patients were positive, and only 2 of these patients were positive for the SRA and then be confirmed for HIT. In 2020, so during the same period, during the pandemic, we had 42 patients with HIT suspicion. 19 were non-COVID patients, and 23 were COVID positive patients. Using the 40 score, we were able to exclude 60% of the patients, and we perform anti-PF4 antibody screening in only 9 patients. Only 3 patients were positive, but none of these patients had a positive SRA, and we had no diagnosis of HIT in this period. So we observed, in comparison to 2019, a higher number of HIT suspicion without a corresponding increase of HIT diagnosis. Then we wanted to analyze the anti-PF4 heparin levels after COVID vaccination. So using the cohort of patients include before COVID-19 and before COVID vaccination, 7 patients were positive for anti-PF4 antibodies. With the cohort of control in 2021, none of the patients were positive before vaccination. Only 1 patient was positive 28 days after vaccination, but 3 months after vaccination, none of these controls were positive. Concerning the control groups of healthcare workers, at baseline, so before vaccination, 7 were positive, and after vaccination, 6 were positive for anti-PF4 heparin antibodies. When we analyze the 61 patients with systemic inflammatory disease, so patients with vasculitis, connective tissue disease, or rheumatic disease, before and after vaccination, only 1 patient was positive for anti-PF4 heparin antibodies and still and remained positive at day 28 and after 3 months. None of these patients with a systemic inflammatory disease develop thrombocytopenia or thrombosis after COVID-19 vaccination. To sum up these previous results, the prevalence of the positivity of the anti-PF4 heparin antibody was low in control before vaccination, after vaccination, and also in patients with systemic inflammatory disease before and after vaccination. Then we analyze all patients admitted for VITT suspicion during this period in our center. We included 32 patients. 11 were vaccinated with AstraZeneca vaccine, 19 with Pfizer vaccine, and 1 with Moderna vaccine. Median age of the patients was 61 years old. Delay between vaccination and thrombosis was 11 days. The type and the location of thrombosis was wide in the cohort, but most of the patients had pulmonary embolism of a DVT. Concerning the laboratory results, none of the patients had a thrombocytopenia, and only 1 patient was positive for IgG anti-PF4 heparin antibodies, and this patient was at a vaccination with a Pfizer vaccine. So, to conclude, only 1 patient was positive with a thrombotic event after vaccination, but the anti-PF4 heparin assay was positive in all the VITT patients we tested. And very interested, all these patients from all these different cohorts with a positive result for anti-PF4 antibodies were negative using the functional assay by flow cytometry. You can see in the figure one example of different patients from different cohorts, but we tested all the patients and none of these patients were positive. We also analyzed the platelet activation of the patient who had a thrombosis following vaccination. We compare a correlation with soluble P-selectin and anti-PF4 antibodies, and we found again no correlation. To finish in this project, we wanted to confirm the platelet activation profile in the VITT using our flow cytometry assay. We had access of 4 VITT confirmed patients for a total of 20 samples. So samples collected at diagnosis for 2 and for 2 other patients at both diagnosis and follow-up. And as you can see, the percent of platelet activation in this VITT patient was high without heparin, with low dose of heparin. The platelet activation was abolished in presence of supratherapeutic dose of heparin, 100 units per ml, or with low dose of heparin plus antibodies against Fc gamma R2 receptor. And all these VITT sample were patients were positive at the platelet activation, at an increase of platelet activation with addition of platelet 4 in the assay, and it was abolished when with addition of platelet 4 and antibody against Fc gamma 2 receptor. And then we wanted to analyze the correlation between the level of anti-platelet 4 antibodies and the percent of platelet activation in HAT patient without heparin, with low dose of heparin, and with supratherapeutic dose of heparin. As expected in HAT patient, we found no correlation between anti-platelet 4 antibody levels and platelet activation without heparin or with a supratherapeutic dose of heparin. We observe only a correlation with low dose of heparin between platelet activation and anti-platelet 4 antibodies. And interestingly, we didn't find any correlation between soluble P-selectin and the level of anti-platelet 4 antibody in these patients. However, in VITT patients, we observed a strongly association between platelet activation and the absence of heparin, but also in the presence of low dose of heparin. With the use of supratherapeutic dose of heparin, the percentage of platelet activation was very low, and we observed no correlation. But in contrast to HAT patients on figure H, the level of soluble P-selectin was correlated with the level of anti-platelet 4 antibody in VITT. So to conclude to all this work, we observed no significant increase of anti-platelet 4 antibodies in COVID-19 patients, regardless of the disease severity. Despite a twofold increase in HAT suspicion during the pandemic, we didn't observe an increase in HAT diagnosis, so no link in HAT and COVID-19 infection. After vaccination, we didn't find a significant increase of anti-platelet 4 antibodies levels, particularly in systemic inflammatory disease patients. The prevalence of the anti-platelet 4 heparin antibody was very low and seems not different from the prevalence in the general population previously described in the literature. Interestingly, in VITT patients, but not in HAT patients, anti-platelet 4 heparin antibodies were correlated with platelet activation, suggesting a distinct role of these antibodies in the pathophysiology of VITT. But this result should be confirmed in other studies. So the relevance of anti-platelet 4 heparin antibody is very poor outside the clear setting of thrombocytopenia and thrombosis. And anti-platelet 4 heparin testing should follow current international guidelines for HIT and VITT-like diagnosis. Thank you for your attention, and I thank all the members of the study, all the grants we received for all this work, and the patients included in the studies.
Thank you, Nicolas, for this excellent presentation. And I mean, this is an impressive amount of work. Actually, while the audience types their questions, I was wondering, how did this start? Just to how did you get all these people together and convince everyone to collaborate on such a big study?
It's a very good question. So in our hospital, I think because some of the cohorts were made in our hospital, so we could include all these patients, but we have a good collaboration, for example, with Johann Staller in Vienna, who give us access to VITT patients, and we could have access to, because during the beginning of the COVID-19 vaccination, people developed cohorts of serum of plasma to evaluate immunity. But after the VITT pandemic, we could have access to this plasma sample for research. So it was very interesting.
Yeah, and one of the very interesting thing, at least to me, was the correlation with soluble P-selectin. So just a question, when was this plasma sample taken for soluble P-selectin?
So it's a very good question. It's one of the major limitations of our study, because as I stated before, it's only 4 patients with a total of 20 samples, and so all the samples were at diagnosis, and only for 2 patients it was during follow-up. So in a statistical manner, it's a correlation using the same individuals. So it's a limitation, but patients with VITT are very rare. So it's difficult, but it needs to be confirmed.
Yeah, but it's it's interesting that in HIT you don't see this at all, and it's very specific for VITT. So do you think the antibodies are they different types of antibodies that are or immune complexes that are present in HIT versus VITT, and in the way they react with Fc gamma R2A, could that trigger different types of thrombotic mechanisms, you think?
So we already know, thanks to Andreas Grenacher and Ted Varkantin, that HIT antibodies and VITT antibodies are different. But yes, according to our results, maybe the VITT antibodies are more, more pro-platelet activation, and maybe HIT antibodies have a role on platelet, but maybe more a role on netosis, maybe to induce thrombosis. So maybe the thrombotic events in VITT are more related to platelet, and in HIT, there is a different pathway that induces thrombocytopenia and thrombosis.
Yeah, I think this will be very interesting to follow up on. I'll now bring up some questions from the audience, and the first one is from Stephen Hawley, who asks, you are only looking at PF4 heparin IgG antibodies. Is it possible that some patients have IgG that recognize PF4 with some other components?
So we also did we also performed these studies anti-platelet 4 antibodies IgG using the live code assay. This assay is specific for anti-platelet 4 antibodies, and it was shown in previous study a good sensitivity for VITT diagnosis. We analyzed all this cohort with this assay, and we didn't find major difference we only have the feeling, but it's only a feeling. We need to prepare the paper that maybe the sensitivity of the live code IgG anti-platelet 4 antibody was maybe very high in comparison to the Zimu test assay, and maybe led to more functional assay than the other one.
Yeah, very interesting. The next question from Michael Macris. Do you have any recent data on the titer of the anti-PF4 in your VITT patients? Is the OD going down, and do they show platelet activation?
I don't have the slide here, but in the supplemental of this paper, we only analyzed 4 patients with VITT with this assay and with anti-platelet 4 heparin antibodies. And we found, as other previous paper, that antibodies decrease in time, but slowly in comparison to platelet activation. And we found a different platelet activation according to time with addition of platelet PF4 or heparin. It was only in 2 patients, but we found that the platelet activation changed according to time and also according to heparin or anti-platelet 4.
Yeah, very, very interesting. And then last question from the audience, from Colin Evans. Do you think the net effect of platelets in COVID-19 is to worsen injury or protect against injury, and how?
Sorry, can you repeat the question?
So do you think the effect of platelets in COVID-19 is to worsen injury or protect against injury, and how?
I think many papers have shown that the platelet activation is increase the severity of the disease, because I think the COVID-19 severity is driven by microthrombosis, and many studies shown that von Willebrand factor increase during the disease as a marker of endothelial activation is linked to mortality, but more von Willebrand factor release and use more platelet activity, and yes, microthrombosis mediated by von Willebrand factor and platelet activation induce the severity of the disease, in my opinion.
Yeah, I think the role that platelets play in COVID is probably very complex, and I think the clinical trials, while they were neutral or negative that tested antiplatelets, I think one of the limitations is the heparin was so good, and then you're trying to look something that's even better on top of the heparin, I think, and so, but yeah, I think platelets play so many roles. So there's another question from the audience from Quintain Bonnet. Thank you for this interesting presentation. Do you think it could be relevant to also have a look at other antibody subtypes besides IgGs?
I think it will be interesting, but when we did, because in HIT we know that only IgG are pathogenic, so it's recommended to do IgG testing in HIT. Some people still using IgM or IgG, IgA, and IgM testing that lead to an increase of false positive. But concerning VITT, I think it was only IgG that were described, but it could be interesting if people have cohort and time and other kit to test this hypothesis. But in my opinion, only IgG are pathogenic.
Thank you. And I mean, to circle back, I mean, one of the key take homes is also like that we should not be testing too much, I guess, right? So maybe you could summarize again, because to me it's also interesting, right?
I think to summarize, we need to only I think anti-platelet 4 antibodies need to be tested or searched only in case of thrombocytopenia and thrombosis, in case of VITT, or only in thrombocytopenia in patients under heparin according to guidelines. So, and I think thrombocytopenia leads everything is a good biomarker and simple.
Yes, yeah, and I think that became very clear, and I think that's what I think makes this publication from you and your team so impactful, because you have all these different cohorts that you compared. So, if there's no more questions from the audience, I would like to again thank you, Nicolas, for this excellent presentation and giving us the opportunity to have an inside look into this paper. We hope the viewers will read the full details of your paper on our site, rpthjournal.org. Thank you to everyone for joining us today live, and don't forget to follow us on LinkedIn, Facebook, Blue Sky, X, and YouTube. Thank you for watching, and keep an eye out for the next RPTH recap. Thank you.